Hello, I'm Llewellyn King, the host of CFS Alert. Today we're very honored, and I am quite delighted to have Leonard Jason, a name to conjure with in the world of this disease. He is with DePaul University in Chicago, where Lenny is in fact not a physician, but a professor of psychology and the director of the Center for Community Research. Lenny, welcome to the broadcast. Tell me, how did you get involved? You've been so involved, so deeply involved for so long. I think we last interviewed you 9 years ago. How did you come to be so concerned with the plight of ME sufferers?
Well, actually, this began 30 years ago when I was doing very well in academia and was a full professor at DePaul University. Had many grants and was very successful. And when I was 39, I had a bout of mononucleosis. And after getting very sick, I actually left the university for about a year. And I just really was that sick. But I was one of the privileged people that had a job. They wanted me back. I brought in so much money into the university that they felt that if I could come back, we could recapture some of that funds. So I did come back, but I came back really just working an hour a day and slowly built myself back up. And it really took me a long time, but I'm very successful that I'm one of the few people that did not get excluded, did not get, really banished from the working world, which, as we know, happens to many patients with this illness. So when I came into this field, I started reading the literature, and Judy Richmond, who's a epidemiologist, sociologist at the University of Illinois, I began corresponding with, who had been in this field as well. And we began writing basic epidemiology. And we spent 10 years trying to get a grant funded, trying to get the funds, trying to do the grant, because we felt the most important thing at the time was to actually find out how many people had this. And that's what we spent the 1990s working on. It took us 10 years, but we actually ended up coming up with some pretty good results, because before that, it was really considered a rare yuppie flu disease. And after our research, which suggested that there were almost 1 million people with this illness, most of whom had not been diagnosed, and that was an important set of findings that put me into a position to ultimately influence some policy.
Lenny, before we go on, you must tell me, what is that background behind you? It's very dramatic.
This is Cordial Commons. It's a hallway that is for celebrations. All the presidents of the university have their portraits in this particular hallway. And if you could believe, it's based on a British design.
Well, I can believe it, surely. You've covered so much. There's very seldom I come upon a discussion of this disease that people don't say, well, Lenny Jason said, or Lenny Jason's study showed. How many studies have you done? Give us some sort of précis of your work and what it has covered in these 30 years.
So we have over 100 publications. We've had funding from NIH consistently since 1995. So that's pretty good in this area. Basic research we've done has really involved three things. One is we're particularly interested in basic epidemiology for adults and children. And by the way, when we do epidemiology, we do not rely on physicians as gatekeepers. We go right out to the community in community-based efforts. And when we identify cases, we do thorough workups, medical and psychiatric. So we basically make sure we know whether a case is a case. And that is something that somehow has not occurred in far too many studies, a real rigor in terms of case ascertainment and diagnostics. The second issue that I've been focusing on is basic diagnostics. How do you define what is case? And truthfully, we probably are the only illness that actually doesn't have a consensus that has a particular case definition. So I've spent a lot of time looking at the different case definitions, comparing and contrasting them, and suggesting what could be a possible way of basically categorizing patients into those who possibly have something that might be called ME/CFS and those who might have something that's called ME. And you need to recognize that sometimes when I produce papers and I separate them into these two categories, the editors say put it all into one category. So I often get a lot of back difficulties in terms of publishing these two different types, which I do believe exist. And the last thing, just to mention, we're particularly interested in prospective longitudinal studies. And what that means is we want to catch people before they get sick. We want to look at their characteristics so that we can then figure out, are there predictors as to why some people get sick and stay sick and some people don't. But to do that, you need prospective longitudinal studies. And that's what we've been, again, spending about 10 years working on recently.
Can you tell us the difference in your mind between ME and CFS, the differentiation that you've established?
Yeah, I mean, basically, it's not that difficult. You know, if you meet the Fukuda criteria, you basically have 4 out of 8 symptoms, and you basically have something that's probably less severe. And there are, you know, I think that there are a number of people who do meet the Fukuda criteria, and that's what's called the CFS. And if a person doesn't have that many symptoms or 4 symptoms, it would be called chronic fatigue of 6 months. The folks who meet what we think of as more severity are individuals who would meet something like the Canadian criteria.
Can you refresh us on the Fukuda criteria?
So the Canadian criteria requires things like post-exertional malaise, unrefreshing sleep, cognitive impairment. Those are the 3 classic symptoms. By the way, they're also in the Institute of Medicine report, which is good. So you need to specify that in the Fukuda criteria. Just think of it. You can be classified as having CFS without having post-exertional malaise, without having cognitive impairment, without having sleep difficulties. Matter of fact, you can have those 3, you don't even have to have, and you can still meet criteria for Fukuda. That's the problem with the criteria. That's like a shopping list. You pick which symptoms you want, and it basically, you don't require it. So that's the problem with Fukuda.
This brings us to the issue of how many people are in fact sick, and it's a very hard one to answer. When I started writing about this, people said 1 million, then it got up to 2.7 million in the US and 17 and much higher abroad. What is your sense of what the true number of sufferers in the US is?
Well, that's an excellent question. You know, in part, it's epidemiology, basic epidemiology. That's what prevalence research is, but it's based on diagnostics. So you almost have to say, what is a case and what isn't a case? Until you basically determine that, your prevalence numbers are going to change. So if you have a wide category, for example, which some people use, which is maybe Fukuda, or even broader, like just saying chronic fatigue, then those numbers are going to go into the millions. Because let's face it, at any one time, if you go up to people and ask them if they're fatigued, 1 out of 4 people will tell you they're fatigued. And it's not uncommon to go up to people and say, well, you study chronic fatigue syndrome, and they say, oh yeah, I have it too. They don't have it. 4% of the population has what we think of as kind of 6 or more months of fatigue. That's a very large number. But of those, probably maybe, again, it's a small percentage that actually have what we think of as ME/CFS. And that's what's so difficult. One needs to make these distinctions. And if you don't make these distinctions, it has all types of havoc for epidemiology, for treatment and for etiology, because you're never going to get it right unless you all have some type of framework of saying, this is a case, this is not a case, and we can compare findings across different laboratories.
You're a psychologist. That's your training, right?
Yes.
And how does that fit into studying this disease? Does it play a role?
Oh, absolutely. There are so many ways to go wrong in studying this illness, as we well know. And if you talk to the patient advocates, who really understand what's going on, it's easy to miss it. And as a psychologist who has training in mental health issues, I do bring something unique to the area. Number one, there's three things I bring. One is I bring something about rigor. I can basically sort of say we can set something up to study it in a way, for example, epidemiology. We can study epidemiology by going directly out and make community-based samples rather than having physician gatekeepers where we're going to get underestimates. So as a psychologist, I can come up with research methods that make a difference. As a psychologist, I can also differentiate diagnostically. Do you have classic depression, or do you have something that might be called ME/CFS or ME? And let me tell you the difference. A real easy diagnostic tool. If you basically ask a person who's clinically depressed, if you were well tomorrow, what would you do? The person would say, I'm not sure. You go to a patient that has ME and you say, if you were well tomorrow, what would you do? They're going to give you a list of 10 things. So there's a psychological difference between these two entities that needs to be differentiated. The third thing that I, as a psychologist, bring to the table, I am trained as a clinical and community psychologist. Community psychologists are very interested in partnerships. We want to work with groups, with the community, with patients. We don't want to tell them what to do. We want them to lead the way. We want them to help us understand the phenomena of interest. We want to have partnerships. When we develop measures, we want them to be involved in the development of the measures. It's a very different way of doing research. And our research is basically fundamentally community-based participatory research. That's what we believe in. All our research is based on that.
Okay, and tell me, in all this long time that you've been working, have we made progress? Are we further forward? Sometimes it seems as though there's a constant battle to get funding for research, but what can we point to that has been discovered? What achievements are there?
Actually, some pretty important ones. Let me kind of give just a few, if I can. One is that we now know this is not a rare yuppie flu disease. That was what people thought in the late 80s, early 90s. So that's something that has changed. We now know that it's something that affects quite a few people of every race and of every socioeconomic status, okay? So we know that it affects lots of people, and we actually have research from Africa that suggests it's there too, in rates at least as high, if not higher. So, okay, so that's something we know now that we didn't know initially. That's important, okay? Another thing that we know that we possibly didn't know before is something that involves the biology of this illness. We have ways of looking at different systems in the body, for example, the brain, to actually look at how neurons are transmitting impulses and how these networks basically are functioning. And we can actually go into the brain and we can kind of see where there's problems through both MRI and Loretta systems. So there are ways of us doing dynamic systems. And by the way, the things that happen in the brain are happening in microseconds. So if you want to look at communication difficulties, we can really begin to understand those things. Number three, we have methods that can basically stress the system to actually see the irregularities in pathophysiology. And the two ways that we can stress the system are the two things that involve both standing up, which we can then find out through orthostatic intolerance. And people like Peter Rowe and others have basically pioneered that type of work. Maureen Hansen is doing some great work on that at Ithaca. And then we also have exercise challenges through cardiopulmonary vascular systems. Stacy Stevens and others has done tremendous work in that area. So we know now, Alan Light's another person who's done great work in that area. So we have sterling investigators who know how to get to the phenomena that's so important for us to document. And I'm telling you something, 30 years ago, we did not have those methods that we have today.
And I'm so glad you mentioned Africa. I want to go there. We tend to talk about this among ourselves in this community, and I'm a sort of observer of the community, as though it is a Caucasian disease, a white disease, but it isn't, is it? And why is it we see so little representation of African Americans, Asian Americans, Indigenous Americans?
Well, it's a very good question. Gloria Njoku, who is a former student of mine from Nigeria, did a community-based study in Nigeria and actually found prevalence rates that were at least as high and a little bit higher in the US. So that's you know, again, an African population. So why is it that we possibly don't see that? We just finished a study of children from 5 to 17, where we basically contacted 10,000 and brought into evaluations medically and psychiatrically to work them up. And what do you think? The folks who we identified as having this illness, ME, they hadn't got a diagnosis. So they had all the symptoms. They were not doing great as youth, as you'd imagine, but they didn't have a diagnosis. So the number of places you can go to get a diagnosis, the number of places you can go to get treatment, that is the problem we're facing now. That there's such a lack of basically systems out there that can deal with the numbers of people that have this illness. And by the way, COVID-19 is rumbling down the road, as we know. And that is, millions of people have gotten COVID. And we think a certain percentage of them are going to fluctuate into this ME/CFS category. And what do we do with all those people? Because I get phone calls from them. I get emails from them. I know that the symptomatology of a number of them are very comparable. And that's going to be a whole other group that is going to need services that we need to think about how to develop them. We haven't developed good services for ME/CFS over the last 30 years. And my fear is the same thing's going to happen with the long haulers.
My impression, Lenny, is that if anything, we've deteriorated the services. We've increased the research, but the actual services have declined or remained static, and they're very spotty. There are states where there are no doctors treating it. Very few doctors are qualified to give you an analysis of what you have, to do a diagnosis. And that seems to me to be a huge human crisis with this disease at the moment.
Yes, I'm 100% supportive of what you're saying. Let me try to explain what's going on here. In a sense, you have physicians who basically get paid often by, in a sense, how many procedures they do. And if you do fewer procedures and your patients take more time in the medical practice you're in, you're going to make less money, and your colleagues are going to basically be looking at you askance. Patients who have ME and individuals who have these complicated disorders are going to take more time. And that basically is something that our healthcare system does not invest in. And physicians get penalized for that. So they basically are less happy and willing to serve this very in-need patient group. So that's one issue. It's complicated, and there's basically, that becomes a problem. The second issue is diagnostics. You've got primary care physicians who have like 30% of their patients coming in with, what do you think their complaints are? Pain and fatigue. And they're not sure what's wrong. So they get many people coming in who have all types of lifestyle issues that are causing their symptomatology. And what happens is physicians get used to, and healthcare workers saying, well, it's probably lifestyle, just exercise, take some antidepressants, do this change. And they don't realize that there's a percentage of those patients who these types of recommendations is not going to be helpful.
Are we spending enough money on research? And if we had more money, where should it be spent?
Well, yeah, I mean, that's an excellent question. I personally think that we could be spending more money on research, and I'll tell you why. Because if we can conquer this particular illness, if we can figure out the pathophysiology of this illness, if we can kind of understand all the different systems that break down, that will be an enormous boost to us understanding medicine for many other people. And let me tell you, it's very similar to the AIDS issue, because once we understood the AIDS virus, the benefits to medicine have been outstanding. And so that we can learn so much from these unexplained types of illnesses if we invested more research and more funding in it. So yes, I definitely think that that's something that could be done.
What else would you like to see? At one time you talked about having some kind of residential homes for people with ME, and it was an interesting idea. Do you still believe that's a possibility or a good concept?
Well, it is going on. There are people who are living in community, sometimes with one person, sometimes in a village, particularly in the multiple chemical sensitivity community, where you have a group of campers who are in some places in Arizona. But let me tell you, I have spent decades studying an organization called Oxford House, which are individuals who are dealing with substance use disorders. And they themselves started the first house in 1975, first Oxford House, 7, 8 people, they self-govern and they pay their bills. And there's no professional staff that runs the house. Do you know there are these Oxford houses in every community throughout the United States? There are over 20,000 people today living in these recovery homes in community. That's a model. In a sense, we can conquer some of our issues because, you know something, social isolation is a risk factor as prominent as tobacco for long-term problems. So if you basically bring a person into a single occupancy hotel and you make them have a television set that becomes their best friend, that's the worst thing you can do. And with the COVID pandemic that's occurring, we need to be thinking about how we can create community, because that's what people need. And a lot of people who are sick, truthfully, don't have communities. And they don't have, because for one reason or another, they need those communities. So yes, the psychological sense of community, which is something that I study, is so important to break down loneliness from people who have frayed social connections because they've been rejected so often by healthcare systems, by work settings, by sometimes even friends and family members. So yes, we absolutely need to think creatively, out of the box thinking, to basically make a dent in this problem.
Lenny, it is such a pleasure to have you back on this broadcast. And I want to tell you that I think you are a truly great man and you do fabulous work. Thank you.
Thank you.